Welcome to the Neuroblastoma Parent Global Symposium and Neuroblastoma Australia's Family Conference, which this session is live streaming across. My name is Josie Dimitriou from Children's Cancer Institute, and I'll be moderating this session entitled Progress in Neuroblastoma Clinical Trials, Where We've Come From and Where We're Going, delivered by Dr. Toby Trahair, paediatric haematologist and oncologist at Sydney Children's Hospital. If you are watching from the Neuroblastoma Parent Global Symposium, I'd like to draw your attention to the panel on the right of your screen, where you can submit your questions. There's the option to do so anonymously if you would like. Questions will be addressed after the presentation. Over to you, Dr. Trahair.
Lovely, thank you very much. It's a real privilege for me to be able to be speaking to you today. So I'm a paediatric haematologist oncologist. I work at Sydney Kids Hospital at the Kids Cancer Centre, as Josie said. And on the top of the screen there, that's a magpie. And a magpie is an Australian bird, and they're big scavengers, and they will like pick the eyes out of good things. And so what I'm really trying to do today in talking about neuroblastoma is a bit more philosophical. It's about what progress has been made in clinical trials, and I think what are some of the key challenges in going forward with clinical trials at the moment. So as you all know, neuroblastoma is a pretty complex disease, and it's got quite unique features, and its outcome and biology is very strongly influenced by both age, the biology and the genomics. And so in younger children with non-high-risk disease, paradoxically, it's a disease where we don't seem to need to do much in terms of treatment, because there's a very high chance that the tumour can regress or go away. But yet in older children with unfavourable biology, it's a really aggressive disease, and it has a poor outcome despite progressive intensification of therapy. And one of the dominant themes really in clinical research and trials research in high-risk disease has been ongoing intensification of therapy. So what I wanted to do is just then go through a couple of slides, which is really about where we've come from in terms of clinical trials. And I think, it's been really lovely to see over the last 20 to 30 years, there's been a wealth of clinical research and clinical trials data that have been published internationally. There's good collaboration between the different trials groups, and a lot of the information is highly influential in the way people think about treating and managing neuroblastoma. And so non-high-risk neuroblastoma, there's been a lot of data published, and a lot of this data is all around the concept that non-high-risk disease is biologically favourable. It's got a high chance of actually spontaneous regression. And often, if you do need to use therapy, excellent outcome with minimal therapy, often surgery or observation. Some children do need chemotherapy. There are a small number of kids who have high-risk disease, particularly older patients with localised unresectable disease. There's been some really nice work done by the Children's Oncology Group recently looking at the risk of poorer outcomes for infants with what we call MS disease. And again, there's been some really interesting trials that have been done in rare neuroblastoma, opsoclonus myoclonus. Again, there's been a lot of published data in trials in high-risk neuroblastoma over the last 20 years, again, by many groups. And again, a lot of these studies have been very influential, and the study results have been influential across all study groups. And a lot of this data has been incorporated into upfront treatment for children with high-risk neuroblastoma. So there's been data and trials looking at randomisation between different induction chemotherapy regimens. There's also been the introduction of consolidation therapy and refinement of consolidation therapy, which is an active area of research. There's also been research that's been done looking at the role of surgery and complete resection of the primary tumour for children with high-risk neuroblastoma. And we know that in the post-consolidation phase of treatment, there's been a lot of work on immunotherapy, and that's been one of the real successes in academic clinical trials research in neuroblastoma, has been the introduction of immunotherapy. And also there's been sort of really nice data published in the last few years by St Jude's Hospital showing that you can actually use the immunotherapy, the antibody anti-GD2 safely with induction chemotherapy. And the Children's Oncology Group have also done a pilot study of that as well. And again, even in the context of relapsed and refractory high-risk neuroblastoma, there's been a lot of data that's been published and a lot of successful clinical trials. And again, this is really just a bird's eye view and a sort of a selection of some of those. And again, really one of the dominant themes in relapsed refractory neuroblastoma is actually been the successful use of immunotherapy in the relapse setting, having good trial design that allows you to identify active therapies with a small number of patients, but it demonstrates the importance of efficient trial design. There's been some work also on lots of targeted agents, and there's been a lot of excitement about ALK inhibitors, and I'm sure you've been hearing about that so far through the parent conference. And again, there are many other targeted agents that have also been identified, that have also been tested and trialled in the relapsed refractory setting to show that they've got activity. And again, one of the other really important things is there are other avenues of immunotherapy beyond the anti-GD2 antibodies. So vaccine therapy, which has been pioneered by Memorial Sloan Kettering, and there are also CAR T cells as well. So really, there have been quite substantial gains in survival that have really arisen from clinical trials over the last 3 decades, and there are really strong international collaborative clinical trials frameworks. And, you know, over the last 20 to 30 years, there's been improved thinking around staging and risk classification. And as I sort of outlined at the very start, for non-high-risk neuroblastoma, there's much less intensive therapy so than there would have been 20 to 30 years ago. The dominant theme really in high-risk neuroblastoma, though, has been ongoing intensification of treatment. And as I sort of highlighted before, one of the real successes, though, has been the registration of multiple anti-GD2 antibodies, and most of these have come out of academic clinical trials in North America and Europe as well. However, despite this, the outcome for children with relapsed refractory disease still remains poor, and there have been many new treatment pathways and agents have been identified. And so the question really to my mind when thinking about talking today was actually how are we going to go forward? And what I really wanted to do was really talk more about trials and how they work and how we can possibly improve upon them rather than talk about specific drugs and agents. So where should we be going? So we know we've got poor outcomes in relapsed refractory disease, but we also know that the outcomes for kids with high-risk disease aren't as good. So one of the things, or a few of the things that I'd like to focus on going forward were trial populations and clinical populations. And there's an opportunity cost for children who don't have the opportunity to enrol on trials. I think we can look at the efficiency of how we actually conduct phase 3 trials to make sure that there is more opportunity for children to participate. I think it's really important to consider the early identification of high-risk groups at early time points soon after diagnosis. I put forward to you the idea that really we need to be introducing experimental therapy much earlier than we do at the moment because treating relapsed refractory disease is really hard and that it's probably better to intervene earlier. I think one of the really important things that we need to do and are beginning to do now is to incorporate biomarker-driven and personalised research into clinical care. And at the moment, we also have the beginnings of liquid biopsy and molecular response monitoring research that's being undertaken in neuroblastoma, but it's not really been at the point where it's been able to be clinically applied broadly. And so in contradistinction, we know in acute lymphoblastic leukemia, molecular response monitoring plays a really important role in treatment stratification. I think one of the other sort of things that I'd like to highlight is also that we need to also make sure that the clinical trials that we do lead to results that are actually able to be rapidly adopted after they're concluded. And there are some advantages and disadvantages of trial design. One of the disadvantages sometimes of single-arm trials versus randomized studies is sometimes the data is very hard to interpret and it makes it hard for that data to become influential and to be rapidly adopted as a standard of care. One thing that we probably don't talk about enough in managing neuroblastoma is toxicity. And again, I wanted to sort of talk a little bit about that because I think it's an important endpoint. It's also an important experience that many children and families go through. Unfortunately, with high-risk disease, with treatment intensification, we know there's toxicity, and yet we accept that, and as clinicians we say that that's clinically acceptable toxicity, but I think we really do need to be focusing much more on managing toxicity better and also trying to intervene to prevent and reduce toxicity. So also when people talk about identification of new treatment targets in neuroblastoma, it's clearly important to identify things that are going to help us to treat the neuroblastoma. But I think also we need to broaden our concept of actually new treatment targets in neuroblastoma so that some of the new treatment targets we should also be looking at are ways to reduce the toxicity of current therapies. And at the very end, a lot of this is focused on high-risk neuroblastoma, but I really want to highlight that it's also important that there are important clinical populations who have life-altering consequences in non-high-risk neuroblastoma as well. So again, this is two pieces of data. On the left-hand side, it's some data that Navin Pinto was the first author on, which is really a collaborative piece looking at neuroblastoma research over a number of years and opportunities. And this is just really looking at children with high-risk neuroblastoma who are enrolled in children's oncology group trials to show that there was incremental improvement in their survival over the course of 2 decades. And so on the blue line at the bottom, you have children who were treated in the earliest era, which is in the 1990s, and in the redder line up the top, these are the children who were treated between 2005 and 2010. So one of the consequences of having effective clinical trials is we have been able to improve the outcome for kids with high-risk neuroblastoma, and that's really important. However, no matter what gains we've made, the fact that survival's really only at this stage at about 50 to 60% shows that whatever gains we've made, we've still got to make a lot more. The other data graph here is, again, from the INRG data set, and Wendy London was the senior author on this paper. And again, this is a little bit old now, but really the point what I wanted to make here is that for relapsed refractory neuroblastoma, it's a really hard disease to treat with poor survival in the longer term. And so to my mind, it's important that we do trials in both these settings. But I think one of the things we need to think about is, in terms of improving survival, we also need to make sure we focus very heavily on earlier in treatment and in high-risk neuroblastoma, because I think that's the major opportunity that we have to prevent relapse and increase survival. So I wanted to sort of try and talk about the concept of clinical trial populations and clinical populations, because not every child who's diagnosed with high-risk neuroblastoma or neuroblastoma has the potential to participate in a clinical trial. And from my perspective, clinical trials are really important because they are the tool that we use as clinicians to generate information and data to help us understand how we can find better treatments. And for a successful clinical trial, it changes the standard of practice and standard of care, and ideally it makes it better. So the graph on the left-hand side is Australian data about the incidence of neuroblastoma. It's relatively static. And we see about 40 children with neuroblastoma diagnosed every year in Australia, and about half of those are diagnosed with high-risk disease. So we know in the period, say, between 2010 to 2016, when we had one of the CEP and high-risk trials open, there would have been about 120 children with high-risk neuroblastoma diagnosed in Australia. So that's sort of the pool of patients in Australia with high-risk neuroblastoma. At that same time, we didn't have much access to some other high-risk trials from the Children's Oncology Group. And so I know over this time period, out of those potentially 120 children with high-risk neuroblastoma, probably only about a quarter of them actually got onto a clinical trial. Now, it doesn't necessarily mean that the children who weren't on a trial didn't get excellent therapy and didn't have a good chance of survival and as good as children on trials. But the opportunity cost I'm really trying to identify is that trials are really important because they generate data, but they also need patients to actually go into trials so that we can actually answer the questions. And so I think one of the really important things we need to think about is trying to make sure that we can increase the opportunities to make sure that trials are available. Just because they're available doesn't mean you have to participate in them. But I think if there are more patients who are available to go on to trials, it allows us to get trials completed in a more timely fashion, answer the relevant questions, hopefully improve outcome, or dismiss therapies that aren't effective, and then move on to the next question. And the other linked idea in terms of patients who are not treated on trials, it's often really hard to actually access information and data about them. It's possible to be done, but there's less data available. So in terms of having information around and available for scientists and clinicians to analyse to help us to improve outcome, some of the best data sets we have come from registry studies and from clinical trials. And so I think there's a really important value in being able to make sure that we can try and get as much data as we can from really every child and family who's diagnosed with neuroblastoma, because that data is really important, not just for your child, but it's also important for the children and families of the future as well. I think one of the other problems that we really potentially have in the way we do trials is that I think we can improve the effectiveness of how we actually do them. And this is a bird's eye view of one of the recent high-risk trials from Europe, from Symposium. And again, this is a really successful trial. It was open over a number of years. It had a number of randomizations to test different things. So to randomization for induction chemotherapy, randomization for consolidation therapy, randomization for post-consolidation therapy with antibody treatment. And so this trial was open over a period of almost 20 years. Lots of publications came from it, some which are very influential. But if you look at phase 3 trials for kids with newly diagnosed high-risk neuroblastoma, they have actually often very similar common design elements, randomizations to ask the question about one treatment versus another in the different phases. However, there are often prolonged gaps between trials. And so that when this trial closes, there's a phase of a redesign of a new trial, and then it gets opened up, and then you go through all the regulatory processes to get the trial open in all the centres. And so that period can either be really short, or it can sometimes be really, really long. And so if you end up having a gap of 2, 3, 4 years between high-risk trials, it means again that there's this gap of patients where they don't have an active trial open for them, and you have a number of patients where we don't have the opportunity to try and answer the questions, get data, and help us to improve outcome. And so to my mind, I think we need to come up with better ways of how we minimise gaps between trials, and whether or not we actually need to actually redesign a trial each time, or whether we have a framework of randomizations and trials for high-risk disease that allows us to slot in the different treatments that we want to test against each other, and rather than close the trial, just actually add and take arms to and from the trial. And that's a concept that's being used very much in early phase trials at the moment. So I think there's a lot that we can do in the basic structure of how we do trials to actually improve the efficiency to make trials more available. I think one of the other important questions is, when's the best time to actually introduce different therapy for kids where their disease is not doing as well as we'd like? The conventional time to do that at the moment in high-risk therapy is at the end of induction therapy. And so that's what happened in the last high-risk trial for Serpin. And if you had a poor response at the end of induction therapy, you had intensification of your treatment by getting a couple of extra cycles of chemotherapy. So I would put to you the idea that maybe this is not the right time, and that maybe if we had comprehensive and better understanding of the ability to identify patients who are likely to have a poor response either at diagnosis, or if we've got better methods for the earlier identification of poor response earlier during induction chemotherapy, these might be the better time points to have different therapy. I think the other idea is if you can identify patients who are not likely to do as well with what we regard as the current standard of care, it means that you can then actually have different treatments for different subgroups of high-risk neuroblastoma patients. At the moment, most induction chemotherapy programs means that once your child is diagnosed with high-risk neuroblastoma, everybody gets the same induction therapy. But we know that neuroblastoma is a heterogeneous disease. Not every high-risk patient is high-risk for the same reason. So we know there are children with MYC and amplified neuroblastoma. We also know that there are children with 11q deleted neuroblastoma, children with ALK amplification, children with a TERT rearrangement. So it's genetically a heterogeneous disease, but yet we don't really have a specific or a different way of treating children, say, with TERT rearranged neuroblastoma versus MYC and amplified neuroblastoma versus 11q deleted neuroblastoma versus ALK amplified. So I think this is one of the concepts as we're developing more information about the biology of neuroblastoma. We need then to be able to translate through to understanding that biology better, but hopefully coming up with treatments that are a bit more targeted specifically to genetic subtypes of high-risk neuroblastoma. This is a review paper that, together with colleagues at Sydney Children's Hospital and the Children's Cancer Institute, we put together. And again, I'm sure you've heard about many of the treatment targets that have been identified over the course of the last 20 years. And so really this cartoon is just trying to demonstrate that. So one of the real nice things about the biology in neuroblastoma, there's been a lot of advances and a lot of treatment pathways have been identified. So the ALK pathway has been an important one. ODC, DFMO is another important one, BCL2, venetoclax. I'm not going to go through them all, but there are a lot of pathways and a lot of potential targets. And so one of the problems that we also are facing at the moment is actually how do we prioritise and make sure we have the opportunity to test all of these potential agents in a timely fashion and make sure that we can get the best use out of them. To my mind, I think one of the ways around this is that we need to have a better understanding of when you might want to use a particular drug. Is there a particular biomarker or a patient that you can identify what would be best likely to respond to that? And so that there might be a biomarker, say for ALK inhibition, which at this stage is ALK mutation or ALK amplification, and that is coming into clinical trials. But I think we need to be able to find other better ways to actually work out, are there other patients who would, say, benefit from a pathway blocking agent for the MAP kinase pathway. And so this is really where the importance of personalised medicine is coming into, and it's something that's been evolving over the course of the last few years. So this is the idea of poor responding patients, and this is data that Navin Pinto from the Children's Oncology Group was the senior author on, published a couple of years ago. And I think this is a really nice study, and they've taken data from 4 high-risk trials from the Children's Oncology Group. They looked at their response at the end of induction chemotherapy, and really they can show that if you have less than a partial response, these patients do really badly. Their survival is poor. And that's an important finding. But the other thing which I thought was really nice about the data is they did a very comprehensive analysis of the risk factors that they had available. And one thing that they were able to show in a multivariate analysis is that if you had a child with high-risk neuroblastoma with loss of the long arm of chromosome 11, these patients were the least likely to respond to conventional induction therapy. Now, I think this is a really important piece of data because we can identify, and we do identify, loss of the long arm of chromosome 11 at diagnosis. And so it gives us a way to say, actually, at diagnosis, we know these patients may not be responding as well as we'd like to conventional induction chemotherapy. So maybe that's a good group to actually do something different in their induction chemotherapy. And that's really one of the major conclusions that this team from the Children's Oncology Group took away. So we actually have current strategies where we can identify some poor responding patients. Molecular biomarkers for response are also a really important topic in neuroblastoma. And the best example at the moment is ALK. And again, this is something that is coming into frontline high-risk trials now, and you've probably already heard about this in the parent conference. We know that there's a proportion of children where their neuroblastoma has either ALK amplification or a mutation in this gene called ALK. And this is data that's been published by the Symposium group very recently to show that children with ALK mutated or ALK amplified neuroblastoma generally have a poorer response to conventional induction chemotherapy. So there's been a lot of work done over the last 2 years specifically on this pathway. Successful early phase trials with ALK inhibitors, particularly lorlatinib, but done by early phase groups. A lot of work done by the Children's Oncology Group, by the Symposium group, so that now we're going to incorporate the idea of if your child has an ALK amplification or an ALK mutation at diagnosis, they will get conventional high-risk therapy plus an ALK inhibitor. So it's really one of the very first biomarker-driven treatment strategies in high-risk neuroblastoma that's going to be deployed very widely. But I think this is a paradigm that potentially could be important for many other patients as well. You might have already heard about personalised medicine, and I'm sure people have talked about that earlier in the conference. And so this is something that's been done all around the world. And in Australia, we have a personalised medicine platform, which the initial trial we call PRISM. And we do a number of things on the personalised medicine platform. So we sequence tumours to try and find genetic targets. We also try to make models of each individual patient's cancer, specifically in neuroblastoma. For a newly diagnosed patient, we'll try and make a laboratory model of that patient's neuroblastoma so that we can then see if we can actually find in a drug screening program, are there particular drugs that this cancer is very sensitive to? And there are ways that we can then actually validate those in laboratory experiments. So a lot of that is being done at the translational research level, but really what we would like to be able to do is to be able to start to be able to clinically apply some of these results more across the course of treatment. So at the moment, it's probably easiest to look at genetic and genomic data. So if you can identify a patient's got an ALK mutation or ALK amplification, there's a drug to treat that. But there are going to be other drug targets and other genetic lesions that would be able to match up. So we would also like to, going forward in the future, though, be able to take some of the information, if we can show that your child's cancer has got unique sensitivity to a particular treatment, and if we can identify that in a timely fashion, then we'd like to be able to use that information much more clinically. And that's where a lot of the personalised medicine research is going at the moment in Australia and also around the world. And at the moment, our personalised medicine program has focused very heavily on relapsed refractory neuroblastoma, but going forward, we're going to focus much more heavily on newly diagnosed neuroblastoma as well. One of the potential problems of just doing sequencing and personalised medicine at diagnosis is its one time point. Diagnosis doesn't tell you anything about response to treatment. And so this is the idea of liquid biopsy molecular monitoring. And this is a really important idea. It's been around for a very long time, and there's been lots of research done all around the world, US, Europe, in liquid biopsy. But the idea really behind liquid biopsy is that you get actually multiple chances across the course of treatment to assay how treatment response has been going. And so this could be done by looking for biomolecules from the tumour cells in the blood or bone marrow throughout the course of treatment. And as I alluded to at the very start of the talk, in acute lymphoblastic leukemia, molecular response monitoring is the major tool that we use to help change therapy in children with acute lymphoblastic leukemia. So molecular response monitoring is not as well developed in high-risk neuroblastoma as it is in leukemia, but perhaps the real promise will be that we'll be able to use it much more effectively going forward, so that we'll be able to identify patients where their disease response isn't really as good as we'd like at much earlier time points. But then potentially also one of the really exciting possibilities of some of the technologies that have been developed for liquid biopsy is if we can potentially detect the emergence of resistance to treatment at very early time points. So again, this is one of my magpie moments, and this is a figure that I've taken from a recent review paper done by European colleagues. And again, I think this is a really nice paper, and they were looking at the promise and the pitfalls of molecular response monitoring liquid biopsy in solid tumours in children. And so really this is trying to illustrate the idea of what liquid biopsy can potentially offer to treatment programs for children with high-risk neuroblastoma and other solid tumours. With conventional treatment, a child gets diagnosed with neuroblastoma, they have lots of tumour at diagnosis, the tumour responds to treatment, and you proceed along with your treatment. But we don't, at the moment, really have a good way of being able to understand, are there a small population of cells that are there that are resistant to treatment? And so some of these cells that survive standard therapy will develop mutations, and we won't identify them. And the point we identify them, that's when you have an overt relapse of your disease. And so then you need to go into the relapse refractory pathway. So the real promise really behind liquid biopsy is the idea that if we've got sensitive measures of being able to measure treatment response, but also to say monitor for the emergence of resistance mutations, we can pick them up a lot earlier before you've had an overt relapse, and then actually change therapy before you have an overt relapse, and hopefully that will improve survival. And that's sort of an idea that's really taken from the leukemia world, and that does work quite well. We know in leukemia, if you have poor responding leukemia, if we intensify your therapy, we can improve your outcome. So we would love to be able to adopt this paradigm in solid tumour treatment, specifically in neuroblastoma. And we know from a lot of the genomic papers that have been published looking at relapsed refractory disease, there's a whole suite of common mutations that are seen in potentially targetable pathways that occur in relapsed refractory disease. So there's a reasonable possibility that we should be able to identify the emergence of early treatment-resistant disease. I think one of the potential pitfalls of liquid biopsy, though, is there are multiple different methods that you can potentially look at liquid biopsy. And so I think one of the real challenges for us as clinicians and scientists is to make sure that we actually do this research, we do it effectively, we don't get bamboozled by the lots of different options in science, but we focus very heavily on this, and we work out which techniques work well, what their advantages are, what their disadvantages are, and when we can apply them. And so there are lots of different things we can potentially look at in terms of secreted molecules from the tumour itself in the plasma, and you can also look for circulating tumour cells as well. One of the focuses we have in our institute, the CCI, is we're very heavily focused on minimal residual disease and liquid biopsy. We know it works very well in ALL, and so we've been focusing recently also on developing very sensitive assays for children with solid tumours, and this is a little bit of the work that we've done. But again, there's lots of work that's been done by the Children's Oncology Group and by other colleagues in CERP, and again, looking at lots of these technologies. So to my mind, I think this is one of the real challenges that we need to adopt into clinical trials, is to make sure that we can rapidly get to the point we've got really sensitive measures of disease response monitoring, and so that we can use them effectively to help guide us treat children with neuroblastoma better. So really what I'm trying to sort of say is, I think going forward, what we need is to be able to incorporate a lot more information about the individual patient's neuroblastoma at diagnosis. This is from precision medicine programs. We also then need to incorporate much more information about how the early response to treatment is going, and this comes from the liquid biopsy. And so this idea where you might have a single induction chemotherapy, I think, to my mind, we need to actually think about how we do this better and how we have it more targeted either to the specific genetic subtype of neuroblastoma or based on individual response. And so I think one of the other things we also need to do is have slightly more sophisticated designs in the way we do trials for high-risk neuroblastoma. And so again, this is the central sort of hypothesis we were putting forward in the review paper that we did. And the idea being that if you have a child who's newly diagnosed with high-risk neuroblastoma, you have your standard staging and molecular characterization. But then if you identify high-risk features, or if you identify molecular markers of therapy, then those patients should be receiving the appropriate therapy. So we're taking our first steps with this with ALK inhibition, but I think there are probably going to be many more other disease targets that we could also do. I think this concept of restaging and molecular characterization by liquid biopsy is going to be really important, and so it should offer us further opportunities to refine treatment along the way. Now, I wanted to switch gears a little bit, and this really gets back to the idea of the effectiveness of clinical trials and the rapid adoption of results from trials. One of the things that we want to be able to see from a trial is that you do a trial, you get a conclusive result, and it changes treatment. And a conclusive result is that, yep, there's no difference, the experimental therapy is no better, or clearly the experimental therapy is better. And so this is one of the issues around trial design. And so there are problems that come with single-arm studies. And so this is really sort of a discussion around the concept of single-arm versus randomized studies. And so I think one thing we also, as a research community, we need to be very clear about making sure we generate data in the best possible way that is highly influential and will be able to be easily translated. So sometimes the only option you have is to do a single-arm study, and then that makes it hard to necessarily know, have you really improved outcome? Often when you do a single-arm study, what you need to do is you need to compare the outcomes of your patient group that you've treated on your single-arm study with a historical cohort, and you often then need to make sure you've done some matching between your treatment cohort and the historical cohort. But there are still a lot of confounders that can occur between the two treatment periods. And we know in another disease, in acute lymphoblastic leukemia, if you need a transplant for that, we know that with time, survival's improved without us really changing therapy. And the reason why it's changed is because we've got better supportive care, and there are other non-treatment factors that come into that. So one of the downfalls of a single-arm trial design is that there are some factors we just can't account for. And so, again, one of the real important issues that comes up for a lot of families is they ask us as clinicians, is DFMO, should we be using that as a maintenance therapy? It's an excellent question. And I don't know what the answer to that is, because although the data has been generated, at the moment we don't have a randomised study to show that it improves outcome. And the maintenance therapy question is really important, and it's a question that's being asked in other solid tumours. And so on the right-hand side, I've just got some data from a rhabdomyosarcoma study done by the European Sarcoma Study Group, where they randomised children to receive or not receive maintenance therapy. And it was very clear that maintenance therapy had a small but insignificant improvement in survival. And so as a consequence of doing a randomised study, this is very influential data. And the moment this data became available, that's actually changed the way we think about maintenance therapy for rhabdomyosarcoma, and rhabdomyosarcoma now has maintenance therapy in it. Unfortunately for the DFMO data, we know that biologically it targets an important pathway in neuroblastoma, but at the moment the data we have for us means it's hard for us to know exactly what that means. And so to my mind, in terms of efficiency of generating information, it's important that we do use trial designs that allow us to go forward quickly. Now, toxicity. I think this is really important, and I think one of the dominant themes in high-risk neuroblastoma research has been we will intensify therapy, and we know that treatment intensification has improved outcome. However, that comes at a cost. And we know that there's nerve damage, there's hearing damage, there's kidney damage, there's heart muscle damage, there's impact on fertility, there are second cancers. However, almost all of the trials that we've done have been focused on improving outcome, and they don't focus so much on actually how do we reduce toxicity. And so I think if we are going to continue to intensify therapy for kids with high-risk neuroblastoma, we also need to be brave, and we need to do the trials where we're looking at reducing toxicity as well. So again, I picked on cisplatin. It's a common drug that's used in high-risk neuroblastoma. It's used in other tumours as well. It causes hearing damage. Everybody gets high-frequency hearing loss, can cause kidney damage, can cause neuropathy. This is a trial that was done in hepatoblastoma, so liver tumours, and this is a type of tumour where children just get treated with surgery and cisplatin. And so they were offered a protective agent, sodium thiosulfate, to see if it could reduce the frequency of hearing loss. And in the setting of hepatoblastoma, lower risk disease, surgery and cisplatin plus sodium thiosulfate in a randomized trial, they could show that sodium thiosulfate led to much less hearing loss compared to the children who didn't get it. And in this particular cohort, there was no difference in the survival of those who got sodium thiosulfate versus those who didn't. Whenever you do a trial where you're trying to prevent toxicity, there's always a concern that you might stop the cancer cells from dying and you might reduce survival. So this is really interesting data. However, sodium thiosulfate's not really gone forward in lots of other disease settings yet, because there's been some other data generated by the Children's Oncology Group, which is a little bit more concerning. And again, in this study, it was children with lots of different types of cancers who were being treated with cisplatin, and they could be randomized to receive either sodium thiosulfate or not. And that was kids with hepatoblastoma, germ cell tumours, medulloblastoma. There were about 25 neuroblastoma patients in this trial, osteosarcomas and some other tumours. And it's very clear that sodium thiosulfate reduces hearing loss. And if you look at the whole population of patients who are enrolled in this trial, there was no difference in the survival between those who did and didn't get sodium thiosulfate in terms of survival. But in a subgroup analysis of kids with metastatic disease, there did seem to be poorer survival in those children who got the sodium thiosulfate as opposed to those who didn't. So that then raised the question, maybe the sodium thiosulfate was actually helping the cancer to survive the anti-cancer therapy. And that's a hypothesis. We don't know that. But one of the problems is we've actually not gone on and done further studies just yet, because this type of data has actually led to concerns. However, I think it's really important, though, as we go forward, we very carefully consider what can we do to reduce toxicity. And again, one of the really important things about science and trials is results have got to be repeatable. So this is one study. And so to my mind, although the data is concerning, I think it does mean that we need to think very carefully about having a serious discussion. Do we try and repeat this type of study in a better defined population to see, is this data really true, or is it just a quirk of this particular study and it's not repeatable? Because if we could find a treatment that allows us to use one of our conventional anti-cancer agents and cause much less toxicity, that's really important. Now, you've heard a lot about treatment targets to kill off neuroblastoma cells, and that's really important. And the other idea that I think is really important to put forward is I don't think that the only space that we need to be looking in for improving therapy and new targets is just trying to kill the cancer cells. I think there is need for more preclinical research to identify other drugs that might actually help prevent toxicity. So as we outlined just before, one of the potential problems for sodium thiosulfate is that it may protect the cancer cells from being killed off. So this is work that's been done by one of my PhD students, and his interest in his PhD was around toxicity. And this is about 18 months of his work. And what he was really trying to do was design an assay so you could do a drug screen, so you could identify drugs that would stop neuropathy. So neuropathy is a common side effect in neuroblastoma, and it comes about from using vincristine and cisplatin. And so in this particular assay, we can grow nerve-like cells in a culture dish, and then we can treat them with chemotherapy. And we know when we do that, that the nerves actually die back. But then you can also find drugs that will actually stop the nerves from dying back in the lab. And so this is a positive control experiment that we've done with a drug called oloxine, which is a nerve protecting agent that was originally developed to prevent damage in spinal muscular atrophy and motor neurone disease. And in the laboratory, we know that if we compare nerve-like cells that are treated with vincristine, you get about 2/3 of the loss of the nerves. Where you get vincristine or lizoxime, you can protect the loss of the nerve function, at least in the assay. And the reason why we developed this assay is that we're not necessarily that interested in lizoxime in itself, but it gives us a platform where we can actually then start to find other drugs that might be effective in preventing toxicity. So I put forward to you the idea that going forward, that's one of the important things we should be doing. We need to find better treatments. We also need to find things that we can also do in treatment that allow us to have less toxicity as well. Now, just wrapping up, I wanted to move away from high-risk neuroblastoma. So a lot of that's been focused on high-risk neuroblastoma. But there are other children and families who have poor outcome from neuroblastoma in the setting of non-high-risk disease. And so I think it's also important to make sure that we continue to focus on other areas as well. And so spinal canal involvement in neuroblastoma is actually a pretty common problem. 10 to 15% of patients with neuroblastoma, they actually have their tumour grow into the spinal canal, and it can cause compression of the spinal cord, and it can cause paralysis. So these are a couple of patients who we treated at my hospital. This is my patient. This is one of my colleagues' patients. And again, for this particular patient, there's a child who presented and he had a lump on his back, and he had a little bit of a change in his bladder and bowel function, but really not much else. But when we did the imaging, he actually had a large abdominal neuroblastoma with intraspinal extension. And the reason why his bladder and bowels weren't working properly is the nerves to the bladder and bowels were being affected by the neuroblastoma. My colleague treated another patient, child who presented about the age of 9 months, with an intercurrent cough, cold, runny nose, had a chest x-ray, had a huge mass, and had a very large degree of intraspinal extension in the thoracic spine. And back on history also, this child's motor development was really poor. So this child's paralysed and permanently paralysed as a consequence of the neuroblastoma. So we know that spinal canal involvement often occurs in younger children. And this is data from Germany. So Torsten Seemann put together an analysis of children's spinal canal involvement in neuroblastoma. And as a group, those who had symptomatic spinal cord compression at diagnosis actually have better survival than patients who didn't. But really the consequence of having intraspinal involvement might be that you have a child who is a survivor from their cancer, but they have life-altering consequences because of it. And so you might have a child who's got life-altering changes in motor function, bladder and bowel function, and orthopedic dysfunction as well. And so again, this is data from Torsten Seemann's group, and again, the retrospective analysis of the German data. And the thing that was really, I think, terrifying to me when I looked at this data is that there are pretty high rates of long-term consequences of motor dysfunction, bladder and bowel dysfunction, so up to 30%, and also scoliosis and impaired growth. And so it's a really important problem in a group of patients where their underlying biology, their neuroblastoma, may not be that worrying, but the consequences of the intraspinal extension can be. And so one of the things that the Seemann group's been doing over the course of the last few years is they've actually set up a registry study really to specifically look at this. And really the idea behind this is that most of the data that we have about intraspinal extension up until now has actually been coming from retrospective studies. And so we're now trying to develop prospective data, with the idea being that we want to try and understand, are there features of the neuroblastoma or are there features of treatment that we can do better with to minimize long-term impact on potential spinal cord dysfunction in patients. And so this is an ongoing study, and my colleagues who are doing the study, they've allowed me to show this slide, but really this is just the idea that if you look at the first couple of months after kids present with spinal canal involvement, we know that there are some kids who've got no symptoms when they first present with intraspinal disease. A small number of them will develop symptoms. We know that many children who are symptomatic at diagnosis with mild symptoms, many of them get better, a few get worse. But the rate of improvement in children who've got severe spinal canal dysfunction is much, much slower. So this is a group of patients we really need to do much better in. So I was going to leave it there, and I think we've got time for questions. And I'd like to, thank you for your attention.
Thank you, Dr. Trahair, for your insightful presentation. There are some amazing questions. I'm going to shoot straight through to see if we can get through them all. Okay, first question. Okay. Many parents look at trials in the USA to prevent relapse. They come at a huge cost. Most consultants remain tight-lipped on what trial is the most effective so far. If our consultants won't recommend a trial, parents are forced to use other methods to seek opinions, such as Facebook groups. Why don't consultants want to assist helping parents choose a trial?
Yeah, that's a superb question. Look, I would say that there are a couple of complexities here. I don't think that there is necessarily one trial that is better than another. There has been a lot of clinical trials work that have been done by the German Pediatric Oncology Group, Symposium, Children's Oncology Group in high-risk neuroblastoma, and many of those have been running in parallel. It does mean that at the moment there are slight differences in the standards of care between what happens in, say, a COG centre versus Symposium. It doesn't mean that the COG trial or study is any better or any worse than what's been done in Europe. And I think one of the nice things about the neuroblastoma community is that there is actually a lot of interaction at the level of the trials groups, and often the results are highly influential. So the tandem transplant data that's come out of COG is important. CEPN are going to do a randomised study to look at tandem transplantation to validate that data. And that might end up being what will be the standard of care. And so that would mean that that difference in outcomes will, a difference in treatments will actually be resolved over the course of the next 5 years. In terms of preventing relapse, that's a hot topic, and that's a really difficult one. We get asked that question all the time. And to my mind, I have absolutely no hesitation in recommending any treatment where there is good data to support it. What I struggle with in terms of when I speak to my families is that I think participation in a well-designed trial is a good thing to do. Not every centre's got every trial open and available, and often we have some trials open at our centre that'll be a bit different to our sister centre in Westmead in Sydney, as opposed to what might be available in Perth or somewhere in the US or Europe. It doesn't mean that any trial is necessarily intrinsically better or worse than any other. They're just asking different questions. We all want to cure your kids, and you want your kids to be cured. But really, a trial is asking a question, and the question is really trying to say, is this treatment better than what we're currently doing? And so intrinsically, when I speak to my families, it's important to be very clear that one of the objectives of a trial is to answer a question to help treatments get better, but it doesn't necessarily mean that that specific trial will lead to an improved outcome. And as long as families understand that, I think that's great. But I think there can be a lot of misconception by both clinicians and families that because something's in trial, therefore it must be good and it's going to work. That's not true. There are lots of trials that are negative that show that there's no difference in outcome, and so lots of treatments actually don't survive the trials process and don't go forward into large phase trials. Should you travel for a trial and go somewhere else? That's an excellent question, and that comes up a lot, and it's probably true all around the world. We have very committed families that'll go overseas for trials, and again, there are lots of potential advantages and disadvantages to that. And again, you know, to my mind, one of the problems we had in Australia probably 20 years ago, we didn't have a lot of early phase trials, whereas now we do. So I would say that there's probably less need to travel because, again, although one trial might be seen to be popular on Facebook or any other parent website, in reality, if there are 20 trials for relapsed neuroblastoma or 5 trials to prevent relapse in neuroblastoma, it doesn't necessarily mean that anyone's going to be better than the other. So in terms of making a decision to go and look for a trial, I would say to most families at the moment, we have no data that there are therapies that have been proven beyond what we currently offer to show that they will reduce relapse. There's a lot of potential and hope out there. If you do want to participate in a trial, we try to always speak to our families, and I'm happy to talk to families about what the options are and go through what we think the risks and benefits might be. It's a really complex and difficult area, and I think this also comes down to the basic point that if you're going to do a trial, it's got to be designed in a way that the information is generated promptly and it's able to be interpreted easily and it's influential, i.e. it's a clear result, either yes or no, because there's a clear result, yes, it's going to become the standard of care. We will incorporate that quickly. If it's a negative result, we can say, look, it's a shame it didn't work, and then we can move on and answer the next question. So I think it's a really complex area, and maybe I've not quite answered your question, but I think it's always important to engage really carefully, comprehensively, honestly with families on this question. And again, I would say that what is right for one family is not going to necessarily be right for another family, and it's very important to be open about what's the right thing for an individual based on their circumstances, their child, and then go through what the risks and benefits are going to be for that particular family. And to my mind, it's about having information and providing families information to help you make a choice. And what I say to a lot of my families is I want people to be in the situation where they're happy, they've had enough information to help them make a choice so that they don't, in 20 years' time, regret the process of making the choice, so that they feel that they've had all the information they need to help them make a decision. They can then move on and go forward. And if you want to go and do a trial somewhere else, I think that's great, and we will support you to do that.
Appreciate your honesty, Toby, with that question. I know it was a difficult one. Question 2, why have the cooperative groups not evaluated DFMO and the Memorial Sloan vaccine?
Hot topic. Yeah, look, I think that's great. It's a really good question, and they are, two really exciting therapies. And look, to my mind, this is the thing that comes up all the time, and it's a particular issue for lots of Australian families. They are very keen on DFMO. They're very keen on the vaccine. They've both been done by single-arm studies, and again, to my mind, that's an excellent question, because to my mind, I would love to see randomised data for DFMO. It's biologically a good target. I know that my colleagues at the Children's Cancer Institute have been working on this for a couple of decades, along with colleagues in the US and in Europe. And so to my mind, this is one of the points I was talking about, single arm versus randomised studies. At the moment, when I look at the DFMO data, I think it's interesting. I think it's clearly safe. You can give it as maintenance therapy. I just don't know if it works. And so to my mind, I think the central question to my mind is, yeah, we need to do a randomised study. Now, I'm not on the trials committee of either of the major cooperative groups, COG or COPN, and so I can't speak for how the decisions get made. And this is one of the competing priorities for clinical trials, is there are lots of drugs out there, lots of treatment potentially available. And this is why I think having lots of opportunity for patients to participate in trials is important. There's no reason why we can't design a randomised study for either. But again, we just need to make sure that we've got enough of the patient population available to do that. And I think once randomised data became available for either DFMO or for the bivalent vaccine from Sloan Kettering, again, if they are effective, they will become the standard of care very rapidly. So it's an important piece of data to generate.
We've got about 5 minutes left, so I might just, there are several questions, but I might just select one that's a little bit different. Are there any studies planned to compare efficacy of anti-GD2 immunotherapy drugs head-to-head? Is there any indication in data that one is better than the other?
That's another excellent question, and this is, I think that's a fascinating question, because both the US, the Children's Oncology Group, and COPN, they've actually both developed anti-GD2 antibodies, which are essentially very similar. They're not the same. And I, in Australia, have been involved in trying to help get the European product through the regulatory approval. And one of the interesting things is that the data sets that have been generated, from the regulator's point of view, they always want more data. They want more information, they want more outcome data, they want health economic data. But when it came to the approval for the European antibody, the regulators looked at both the COG and the European data, and they treated them as biosimilars. We don't know at the moment whether they are the same. One might be better, one might not be as good as the other. We don't know. And the only way to answer that question is randomisation. However, I think the other important thing is that there are other anti-GD2 antibodies out there. So St Jude's and Memorial Sloan Kettering have both made anti-GD2 antibodies that are also effective. They are slightly different compared to the ones that have been developed by CAG and Seopen. And again, I think this is probably going to be a relevant area of research. And people have also talked about the pain that you get with anti-GD2 therapy, and there have been some specific changes made to GD2 molecules, antibody molecules, to try and prevent that as well. So again, I think that's a complex area, and sometimes you don't end up doing head-to-head trials for some drugs because it means that they're hard to organise, they involve different companies, and so from that perspective, although it might be a good question, sometimes it just doesn't get done.
Okay. Thank you so much, Toby. I really enjoyed the Q&A session, and I'm really sorry that we couldn't get through all the questions. We have reached the end of the session. I just have to read this little bit out. So if you are watching from the Neuroblastoma Parent Global Symposium, we'll be back tomorrow at 3 p.m. GMT with a session on maintenance therapies and a conversation room focused on CNS relapse. If you're watching from Neuroblastoma Australia's Family Conference, the next session will start shortly and can be accessed from the attendee hub on the event website. Stay safe, and thank you for your time, everybody. Thank you, Toby.
Thanks very much.